John, I don't think I'm on, am I? Is my voice okay without this? Because I can talk even louder than 3 can. So
if you could use the mic
on
for the video,
okay,
that would be
need,
super.
There we go. Check 1, 2. Is it coming through now?
No, see, it's got to be, every AV guy in the country says, just press the button, it'll go through.
So reset too. Oh, there we go.
Hey.
Hey, all right. So when John asked me to do this presentation, I thought it was going to be for oriented people, medical students, nurses, physicians, physiotherapists. And so just this week I found out it was going to be directed towards more our public and people that are suffering with pelvic pain. And so I'm going to use a lot of the medical kind of type slides, but I won't go into the detail that I would if I had these 3, 4, 5, 6 people, just healthcare people. But so I'm going to try to race through some of the slides to generate maybe a little bit more understanding of the whole concept that pain is a disease in its own right. And I really try hard to teach that to people because as a family physician, I'm not just looking after someone who comes in with pelvic pain. I try to look after the entire person, their sleep, their mood, their pain, their activity, everything. So this presentation may have some medical pictures that you might just say, what the heck's that? Please bear with me, but I hope I can explain them in a way that you'll feel comfortable with, that I'm trying to teach the medical providers. So my objectives are to discuss chronic pain as a disease in its own right, review a little bit of the neuroanatomy and of the transmission of pelvic pain, and it's already been discussed a little bit by other very capable speakers. I want to try to classify the pain into a nociceptive or visceral type pain coming from tissue changes like active endometriosis versus neuropathic pain, which is more pain that occurs when the nervous system is malfunctioning. So maybe after surgery and the nerves have been cut and they're malfunctioning. And then go through a little bit about the pharmacologic treatment options that are available for all chronic pain. And once we classify pain into a certain type, then it helps the prescribing physician to choose which type of medication might be best. But overall, medication only plays a small part of someone's recovery and their journey through chronic pain. Because by definition, chronic pain means that it's pain that's lasting long term and we don't have a cure for it. So medication can help people break free of this terrible pain-centered life that people can go into where they're not able to function and do their daily tasks. And so medications may help their pain so they can start to do more activities, improve their social lives, improve their overall function. So by definition, chronic pelvic pain is pain that occurs below the belly button and lasts for at least 6 months. Really all around the world, 6 months is felt to be that time. If someone's had an injury or surgery and they haven't had complete resolution of their pain within 6 months, we call it chronic pain. And I'll talk about some of the changes that happen in the nervous system that cause this disease called chronic pain. There's so many patients, well, everybody wants to know what the diagnosis is. Why do I have this pain? Why is it so severe? And the surgeon says, well, I've done everything I can to take out those pain generators, those areas of endometriosis, or whatever it is. If you're an orthopedic surgeon, you fix the rotator cuff. But chronic pain is a disease in its own right where there's changes within the nervous system itself. Now, chronic pelvic pain may be a cause of one or more different conditions, but in many cases it's a chronic condition due to abnormal function of the nervous system. So the diagnosis is abnormal nervous system, sensitization of the nervous system due to neuroplasticity of the nerves and the brain. So chronic pain is a disease because it's similar to other things like diabetes or congestive heart failure or emphysema. It requires ongoing medical and self-care. It is often a lifelong condition, and no one wants to hear that, but it's important if it's developed into chronic pain, and we may say you have to deal with this for the rest of your life. And all of us, everybody on the team involved, wants to help you live the best life you can despite having ongoing pain. So clients that have persistent or chronic pain really report a lot worsening in physical function, their quality of life is worse. They have to access healthcare services a lot more, even in other chronic conditions. So chronic pain is definitely a disease in its own right. And it's associated with higher risks of addiction, mental health issues like depression and anxiety, just overall changes in their quality of life from those psychologic issues. And again, chronic pain, whether it be chronic headaches, fibromyalgia, chronic pelvic pain, chronic orthopedic problems, is best managed as a multidisciplinary, multimodal. So lots of different types of disciplines like psychology, physical therapy, complementary therapies, and oh good, you're still up on here, it's all different. I got a totally different thing. John, come up here, you gotta look at this, there's something on the page. And so we need to treat our patients with multiple different types of treatment to help them the best we can. And so there's a big difference between acute pain, which is pain that has a biologic purpose. There's an inflammatory situation going on where that endometrial lesion is causing inflammation and turning on the nerves in the area, and it sends a message up to the brain to say, okay, we need to do something about this. We need to take our medication. We need to do a pelvic floor exercise. We need to look after it. But acute pain has a short duration, and it goes away. Persistent pain or chronic pain is a completely different thing. Usually chronic pain doesn't have any sort of biologic protective purpose. Like if someone sprains their ankle, the brain is being told, don't walk around on that sprained ankle until it heals. But if you've developed chronic pain because of changes within the nervous system, there's really no protective biologic purpose. It just creates havoc and messes up your life at so many levels. So when we think of persistent or chronic pain, think of it as a new disease. And I was just looking through these slides earlier today. The next little statement here, when it talks about a new disease, is 15 years old. And still we're having a hard time convincing different medical providers, medical people, physios, whatever, that chronic pain is a disease in its own right. And so this particular person, Daniel Brokoff, who I heard speak in about 2000, changed my career and my outlook on how I manage and how I understand people who suffer with pain. It's not just something that's in their head that's a psychological issue. It is a neurologic change. And so what he eloquently said was chronic pain is not just a prolonged version of acute pain. As pain signals are repeatedly generated, neural pathways undergo physical and chemical changes that make them hypersensitive to pain signals and resistant to anti-nociceptive input. So resistant to everything we do to slow down the pain. And his approach changed how I looked at it, and some of the pictures and stuff I'll be showing are related to his slides. Now here's the problem that happens when someone develops into a chronic pain problem. And we call it the chronic pain spiral. So when there's been an injury or an illness like endometriosis, or they've had surgery that's been required for that ovarian cyst or that endometrioma, it causes tissue damage, and if persistent pain occurs, then they start to worry that this is a dangerous thing. It may not be harming them, but they start to worry that they shouldn't be moving. And so they limit their activities, and they develop tight, weak muscles like Bree just talked about. Then they start to limit their activities, and they get very deconditioned, both physically and socially. They're not going out for social things anymore. They're not going for exercise anymore. So they start to get weaker, and they can't do things. So they start to feel this loss of control. They can't even feel confident they can get their own groceries. And then they get this stigma of being labeled with someone with chronic pain, and you just stay in bed all day. And then they get very depressed. And that reinforces the whole thing again. So they become this pain-centered life where they just aren't able to do anything that they value anymore. So they're spending more time in bed than they want to, they can't do the things they want to, and they're suffering miserably with pain. And so at the end, I'm hoping to talk about how a physician or potentially a surgeon can help people break free of this spiral, but it really takes a team approach with the psychological intervention, with physical therapy, with getting back to normal activity. So my next slides are these medical ones, and so I hope you can just kind of enjoy some colorful pictures, and I'll try to explain what they kind of mean. Now this slide is just to show how many nerves are involved in the pelvic organs. There is a gazillion different nerves that come into different plexus, and it's very complex. Many nerves involved, and then many different structures. like has been discussed already. So this next slide is kind of a cool slide with some little video stuff on it. So this really just shows that in the pelvis in particular, there's incoming nerve messages that originated in the pelvis from little nociceptors. They're little organelles that detect whether there's been inflammation or damage or tissue injury. And those will then turn on the nerve that goes up to the spinal cord. And so that's called the primary afferent nociceptor. And at the level of the spinal cord then, there's changes that occur in the spinal cord where the spinal cord nerves either amplify, so they can sometimes increase pain messages, or better yet, when we want to try to control pain, is that it will modify and reduce the messages going through the spinal cord and then up to the brain. Now at the level of the brain, there's very complex things that occur, because it's not just one little area of the brain that gets turned on for pain. There's no pain center. We call it a pain matrix, where it's multiple different areas of pain that I'll show you in a second. But all of that tells you about the location of the pain, the intensity, but it also brings back memories about, oh man, I had this terrible episode of endometriosis, and it gets you very anxious because of the severity of pain that you could remember when you felt this before. And then that creates different emotions. Now the next system is one that a lot of people didn't know about, including John and I, who's an anatomy guru, that there's a descending control system within the nervous system. So what this is, at the level of the brain, we create these signals that go down to the spinal cord to either slow down, which is what we hope when we're treating pain, or sometimes it amplifies pain messages, depending on what chemicals are being released. And this is all going on at the same time. Upwards, downwards, all this modulation of pain. And so to change this, there are a number of medications that help, but psychological interventions to help with stress, physical things to improve movement, all work within this sort of pain transmission upwards and downward system. Now, one of the things in the pelvis is that the nerves converge in a very close area of the spinal cord. So nerves that are near the colon when you get really constipated or distended, or around the uterus if you have an endometrioma, or say an ovarian cyst, those nerves, as well as the bladder, are coming into a very narrow area of nerves. And so when that information goes up to the brain, it often gets all garbled up. And you don't, the brain doesn't know if is it more uterus pain, is it ovary, is it bowel? And that's part of how our nervous system works. This next one, again, fancy picture, but more or less what it shows is the nerves coming in from the pelvis go across the spinal cord and get all modulated in here, and then it goes up to multiple different areas of the brain that tells us where the pain is coming from, how intense it is. The older system is more called C fibers, which are slow fibers that keep sending messages up to say, is your body healing? Is it getting better? Is the pain still there? Those are the ones that tend to be abnormal in chronic pain. They continually fire messages. Here, just briefly, I can talk about this slide for 10 minutes, is the different areas of the brain that are kind of turned on when there's pain messages going up. And multiple different ones. The somatosensory cortex tells you exactly where it is. The prefrontal cortex talks about organizing yourself to try to think about what you're going to do about that pain. Areas like the hippocampus and amygdala are about memory areas. And so it's a very complex thing, and the brain gets really turned on in multiple areas when chronic pain occurs. And that's why chronic pain can be so distracting. People say, like, I can't focus, I have that fog. I think you talked about that earlier today. The brain is distracted from all these pain messages. Now here's a really important part about this descending or anti-nociceptive system, anti-pain system. What is felt is that this system develops in childhood, probably between the ages of about 4 and 10. And if kids grow up in a really difficult situation in life and have issues that affect the development of this, they may have more difficulty with chronic pain later on because they can't develop the endorphins and the enkephalins in their brain to send down to the spinal cord to slow down pain messages. So kids that have been exposed to abuse when they were little, or just a poor upbringing, may have more difficulty later on with chronic pain difficulties. So this is a part of the nervous system that develops as a young age. And it's felt this is where things like exercise or comfort can create benefit. So that little kid who falls down and scratches his knee and it's not even bleeding, but it hurts like crazy, runs to mom's arms, and mom comforts him, calms him down. And we believe that it's turning on these systems to create the endorphins and different molecules like serotonin that makes that pain almost instantly go down. The knee hasn't healed, but they feel better. So the next slide is just showing a little bit of area where the nerve comes in from the outside and attaches to the spot. Here's where all the different medications work, is at the level of the end of the nerves. So here's where the gabapentins work. Here's where the cannabinoids work, like cannabis. Baclofen that was mentioned in the suppositories. The opioids, they all work on these nerves to reduce the pain transmission through those nerves. So I'm going to go like this. So I'm going to jump right to the sort of the last 4 or 5 slides. I had a bunch of more fancy stuff, but no time for it. So here's where all of us caregivers that are trying to help people that are suffering with chronic pain, we try to get people to break free from this pain-centered life where they're really, their life is just all about how they suffer with pain. So where I come in as a physician that can prescribe medication or do some injections, we try to optimize pain relief with medications. And in the next couple of slides, I'll show some of those medications. But I think my role is also about education, to reassure people that there isn't still another terrible tissue problem inside your pelvis that needs another scope or another surgery. If that's all been tried and our gynecologic colleagues say, you know what, more surgery isn't going to help you, I reassure them and say there's more changes in your nervous system that we can help. But once they get less fear of their pain, they can increase their activity and improve their function. They get increased control, improve their self-esteem, and then they have a function-centered life. They still may have pain. And the pain's with them like a little brother that you can't get rid of. It's a companion there. It's like, go away. You can't get it to go away. But you can still enjoy life and have a good quality of life. So again, this needs multiple different people involved. My role is more the medications, but complementary alternative therapies, physical like Bree, psychological like our next speaker, and then chronic pain self-management programs can all be very beneficial. So this one has been discussed already, the nociceptive type of treatment that has been already really skillfully provided. I'm totally impressed with gynecologists that know this much about medication. Totally impressed. So this is where the anti-inflammatories, acetaminophen, hormonal adjustments, and if severe, then we might consider opioids. But opioids opens a whole nother can of worms and can have as many negative effects as good effects. Now, if that patient has sensitization of their nervous system where this whole increase or upward system is turned on too much and the descending system is not working very well, like in people that have conditions like fibromyalgia, chronic fatigue syndrome, or interstitial cystitis like painful bladder, even chronic migraine headaches, all of the irritable bowel, all of those are felt to be related to central sensitization of the nervous system. This is where you hear about the tricyclic antidepressants. If they aren't effective enough, then we add gabapentin or pregabalin like Lyrica, and then we may add duloxetine, which is Cymbalta, or venlafaxine, which is Effexor. And then sometimes we use tramadol products, which is really underused in our world because they're not covered by our drug plan. The next thing is when it's neuropathic pain. So if someone's had, say, surgery, and many of those little nerves in the pelvis have been cut, and they're sending abnormal messages, they're sending little seizure messages through, you can use medications in this stepwise manner. It's very similar to the central sensitization medications. So the tricyclic antidepressants, often at low doses, or the gabapentin pregabalin, or the SNRIs. Sometimes if it's very localized pain, like in someone who has trigeminal neuralgia, we'll put topical lidocaine, just the freezing on the cheek. Then we often have to use opioids because the pain is so severe and we want to try to help our patients that are suffering so severely. The fourth line agents include the marijuana type derivatives, and it can be either inhaled or taken orally. There is a role for them, and there's been so much propaganda about anyone who uses marijuana for pain is using it recreationally and inappropriately. I can tell you I have lots of patients that find the marijuana derivatives more effective than anything else on this list. We do some sort of different blocks to try to reduce pain, but I won't go into detail. And then I want to just mention that when we go to opioids, which is sometimes necessary and sometimes very helpful, we want to use them safely. There's been things talked about opioid agreements, which is a really good idea at the beginning to make sure that the patient and the doctor understands what is going to be happening with the opioids, like urine drug tests, and we're not going to just crank up the dosage. And if it doesn't work, we're going to taper it and change it to something else. Now, one of the concepts I want to just to tell you a little bit about is there are opioids out there that have lower abuse potential. So like OxyContin used to be the #1 abused opioid in the United States, is no longer the case because they changed it into a formulation that can't be crushed, can't be injected, and so the pills themselves are no longer a drug of abuse. So now there's a lot more increase in the use of heroin and other opioids. And in Saskatchewan, unfortunately, hydromorphone is a big one. It's misused for intravenous drug use or smoking or snorting. But we have all these other drugs, and I don't think I saved that one. Done? So Oxyneo is that one that's not abusable. These ones, tapentadol is called Nucynta. You don't get high from it. It works great for pain, but you don't get high. Targan was mentioned earlier because it has naloxone to block constipation. But if they try to snort it or inject it, they'll have immediate withdrawal. So it's not a drug of abuse. Or these patch technologies that work through the skin. So my last slide, chronic pelvic pain should be considered as a disease in its own right. There is changes within the nervous system due to multiple times where there's pain messages being sent through the system. And it is best treated with a biopsychosocial approach. The way the physician decides what type of medication to use is by classifying the type of pelvic pain into a nociceptive pain, where it's coming from a tissue damage in the pelvis, or whether it's neuropathic with changes within the nervous system, or whether it's centralized pain where the brain has had so much changes from the pain that it's really difficult to reverse it. So we choose those medications, the pharmacologic treatment, to help them break free of this pain-centered life and get them back to a life of function. Even though they may have pain, they can still have a decent life and they can have a good quality of life. So thanks very much.